Good afternoon, everyone. Thank you all for joining us today. Please note that this session is being recorded. If you do not consent to being recorded, you are asked to drop off the call at this time. Thank you. I want to acknowledge the land that we are meeting on in our different places and pay respects to the indigenous peoples of our respective locations. The earth beneath our feet is their life connection, and I am aware of the sense of belonging. I acknowledge this connection and give thanks to all the earth provides and pay my respect to all elders. Again, I would like to say good afternoon and thank you all for joining us today. Welcome to the third Emerging and Re-emerging Infectious Disease Peer Learning Community webinar series. My name is Adriana Marzette, and I'm a Public Health Program Coordinator with the National Indian Health Board. Today, I am today's moderator for today's session. Today, we are joined by Dr. Amy Slagle and Dr. Michelle Wong. Following Dr. Slagle's presentation on the vaccine rollouts, Dr. Wong will describe pathways through which social determinants of health may contribute to higher rates of COVID-19 infection among American Indian and Alaskan Native persons and summarize trends in COVID-19 infection and mortality among American Indian and Alaskan Native veterans. Now, before we start, let's go over a couple of housekeeping. In order to receive continuing education credits for today's webinar, please be sure that you log in and make sure that you log out. That is how we are able to track that you attended the session. Again, this session is being recorded. If you do not consent to being recorded, you are asked to drop off the call. All participants have been muted. Please leave yourself on mute unless you have a question for one of the speakers. However, if you're having trouble hearing at any point during the presentation, please let an NIHB staff member know by sending a direct message to them via the chat box. We encourage you to use the chat box to ask any questions, whether it's a link to a document, a comment about explaining something that has been said or anything. Please do not be afraid to ask a question, even if it's to me. And now I will introduce our speakers. Today, we have Dr. Amy Slagle. She is the medical director at the Menominee Tribal Clinic. She also leads the Menominee Indian Tribe's COVID-19 Incident Command Team. She received her medical degree at the University of Missouri, Columbia School of Medicine, and completed her family medicine residency at the University of Wisconsin-Madison in 1994. Dr. Slagle has been in practice for more than 20 years. She is board certified in family medicine. Dr. Wong is a health science specialist at the VA Greater Los Angeles Healthcare Systems Center for the study of healthcare innovation, implementation, and policy. Her research interests are in health equity and social determinants of health. She has researched racial, ethnic, health disparities in VA, including the ongoing COVID-19 pandemic, and explore the roles of neighborhood-level social determinants of health on these disparities. She received her PhD in public health from the Johns Hopkins Bloomberg School of Public Health from the Department of Health Policy and Management, and a BS from Yale University in Molecular Biochemistry and Biophysics. I will now turn it over to Dr. Slagle, followed by Dr. Wong. So Amy, you may now share screen.
And good afternoon. Thank you for the opportunity to represent the Menominee Indian Tribe and tell you about our COVID vaccine rollout. My name is Amy Slagle, and I became the medical director here about 2 years ago, right before COVID started, and I've been at the Menominee Tribal Clinic for a little over 25 years. Like other Native American tribes, the Menominee have a proportionally high prevalence of chronic health conditions, and those include cancers, inflammatory conditions requiring immunosuppressive therapies, obesity, organ transplants, type 2 diabetes, heart and vascular diseases, smoking, and alcohol and drug abuse, and mental health conditions. Menominee County ranks last or next to last year after year in health rankings by county in Wisconsin, underscoring multiple socioeconomic factors contributing to poor health outcomes and health disparities in the Menominee community. Those factors include high unemployment, high rates of homelessness, overcrowded housing, challenges to obtaining healthy food, increases in drug abuse and overdoses, in a rural location removed from tertiary care and specialty services. Together, these chronic health conditions and high risk socioeconomic factors created a perfect storm of vulnerability as the COVID-19 pandemic descended in 2020. Tribal leaders and members quickly recognized COVID-19 posed a huge risk to life and health, which quickly became a tragic reality. Though COVID appeared late in the community, 25 Menominee died of COVID-19 between November 1st and December 31st in 2020. And this aligned with Wisconsin demographic data, which shows that American Indians have the highest rate of death of any ethnic group in Wisconsin from COVID-19. As news of vaccine development and approval ramped up in 2020, our incident command teams and tribal leaders understood vaccines would be of paramount importance in the local battle with COVID-19. This slide shows our current vaccination rates as of the end of March of 2022. Menominee County and Reservation has outpaced all but one county in Wisconsin in our overall vaccine series administration, and we lead the state in most categories by age range. 80.4% of our residents have received one dose, and 76 of residents have completed the series. You can see on the right that we have over four age groups over 90% have completed the vaccine series. All age groups except for the 5 to 11 group are at least 70% with vaccine administration completion. So I guess these vaccine rates apparently caught someone's attention. And so I was asked to tell our story about our COVID vaccine rollout to you today. So we identify 5 pillars of our success, and those include preparation, our mass vaccine clinics and other vaccination efforts, communication to the public, incentives, and most importantly, the Menominee people. So the first pillar is preparation. Early in October of 2020, we had many discussions in incident command, lots of questions, and not much clear information. Our clinic administrator said we better put a group together, and so we formed vaccine planning committee consisting of our nurse vaccine coordinator, the Menominee Tribe emergency manager, pharmacists, incident command members, EMS, and me, the clinical medical director. We read and reread everything put out by the CDC and Wisconsin Department of Health Services. We listened to every webinar available. We met weekly for 2 weeks. Using COVID funds, we ordered new data loggers, new refrigerators, new vaccine transport coolers. We did tabletop exercises. We made the decision to get vaccine from the Wisconsin Department of Health Services instead of Indian Health Service based on our years of experience with VFC. We communicated with strategic partners, including school officials, casino resort leadership, law enforcement, and we identified sites for mass vaccination clinics. We made a site visit to the high school to determine safety issues and workflow, and we navigated the Wisconsin DHS vaccine ordering system, which was not for the faint of heart or easily discouraged. We felt ready when vaccines arrived late December 2020. So we amassed supplies, we organized them and stored them securely at the high school. A subgroup was put together from incident command, and we organized groups and entities for the prioritization schedule, which was indeed the most agonizing aspect of the vaccine effort. We identified every tribal entity and business and department and determined risks of exposure to COVID by occupation. We generated lists of tribal clinic patients by age or other risk factors from our electronic medical record. We used ACIP and Wisconsin guidelines to determine our priority groups, and we stuck to those guidelines despite some protests. Healthcare workers and first responders were vaccinated at the clinic late December 2020. By mid-January of 2021, mass vaccination clinics were held every Thursday and Friday at the high school, utilizing 2 gymnasiums. We never knew which day of the week vaccine would arrive, which made it hard to schedule these clinics ahead of time. We set up phone numbers in an electronic portal to register for and schedule vaccines. Early on, we welcomed walk-ins in the clinics if they were eligible by the priority system. Every nurse at the clinic received training and information on COVID vaccines. We utilized the entire nursing staff at our clinic and volunteer nurses as vaccinators. We utilized a retired physician and multiple clinic staff for COVID screening, registration, people movers, and pharmacists to drop syringes and monitor vaccine at the clinics. We used retired physicians, retired pharmacists, and retired lab staff who all volunteered their time at the clinics. EMS supplied monitoring 2 to 4 EMTs for monitoring during after vaccination was completed. We used mass vaccination clinic at our high school and then the Menominee Casino Resort Convention Center through May of 2021. We vaccinated up to 800 per week during those months. As vaccine became more available and the priority schedule liberalized, we started offering vaccine to the families of tribal employees and tribal members, believing that all ships rise together. Vaccine clinics were offered evenings and Saturdays multiple times. Vaccines were offered to children at school as soon as they were available. Vaccines were taken to elders and other homebound in their homes, to the assisted living facility, to the tribal jail, into an off-reservation restaurant where many Menominee members were employed. Vaccines were taken to community events and to community centers and to remote areas on the reservation. Vaccine clinic was moved back to the clinic when demand began to diminish in May of 2021. We began offering vaccines on a daily basis at the clinic when the vaccine supply expanded. 3rd doses were given to immunocompromised people starting August of 2021. And since August, vaccination sites have included schools, the Casino Convention Center, the clinic, and the Tribal Recreation Center, depending on demand and targeted age groups. The next pillar was our communication to the public. Weekly public service announcements, or PSAs, started in fall of 2020, providing education and credible information about vaccines. Public vaccinations of key community members and leaders were recorded and distributed as PSAs via YouTube. Coverage by local, state, and national press occurred and we believe helped our efforts. We continued weekly PSAs informing the population as to who was next eligible for vaccines. A weekly podcast was done by our public information officer, answering questions and providing reliable information on vaccines. The College of Menominee Nation did a YouTube broadcast with several students promoting vaccine, and tribal legislators and spiritual leaders did YouTube broadcasts also promoting vaccines. There were many phone calls and emails to tribal departments and businesses alerting and informing regarding vaccine eligibility. PSAs went out on tribal email, all tribal social media accounts, websites, and by distributing paper copies at gas stations, by home care workers and nurses, and in pharmacy refill bags delivered to elders. One door-to-door PSA on vaccines was distributed by law enforcement to every home on the reservation. Next is incentives. And spoiler alert, they worked. We started small. We used COVID funding to purchase t-shirts and buttons and stickers promoting vaccine. We expanded that to include gas cards and grocery store and Subway gift certificates. Next, we had drawings for $200 amusement park gift certificates. The College of Menominee Nation gave $500 cash incentives to all staff early in the summer of 2021. The Menominee Indian School District offered $100 gift certificates to students who completed their vaccination series. And then the big game changer, the Menominee Tribal Legislature approved $500 cash incentives for every vaccinated tribal member, regardless of age, between August and the end of October of 2021. So vaccinations more than tripled in August of 2021 compared to July, and continued at a high rate through the end of the incentive offer. Later in the fall, there were concerns about Delta variant, and that resulted in another wave of vaccination. The last pillar, and I think the most important, is the Menominee Nation and its members. All of the planning and community networking would not have worked if not for the Menominee tribal members who were remarkably accepting and receptive of COVID vaccinations. And these, I believe, are the reasons why. They're a community which reveres its elders and places priority on protecting them. They're a community which treasures its children and believes in public health measures as a method to protect them and thus protect the future of the tribe. They're a community which still embraces taking care of each other and still believes in the common good. They're a community which embraces science and did not make vaccinations a political wedge issue. The Menominee have a history of resilience and survival through which they have persevered, including winning back their reservation status. And they have a tribal government which has been engaged and proactive from the onset of the pandemic to do everything possible to protect the tribal members. As COVID asserts, it will not magically disappear. We struggle to find the human power to continue vaccination efforts on a constant and often scaled up basis. The price of funneling so much of the clinic staff to the vaccine effort was at the cost of lost access to regular care, which is not sustainable and in turn contributes to health inequities, and thus we risk coming full circle. For certain, we will not choose the future efforts needed to respond to COVID-19. The virus will choose that course. We need to work more on boosters. We need to improve our vaccination of children. We still have to convince some of the unconvinced. But we're proud of what we've done so far, and we're very appreciative that the NHIB would note our efforts and ask us to tell our story today. So Wawanan, thank you for your time and listening to our story.
So Amy, while Dr. Wong loads up her presentation, we did have one question in the chat box if you wanted to touch on that immediately while Dr. Wong loads her presentation. The question is, what challenges were experienced with procurement of supplies and equipment, possible competition by many other entities, and what were your resolutions?
Okay, I hope I can remember all the components of the question. We used COVID funding to buy a lot of our supplies, like the storage units, data loggers, etc. We used COVID funding to buy syringes and needles, really everything that we needed for vaccines. If we didn't get it with our vaccines, we used COVID funding to purchase those. I don't know that we had much competition. The Menominee Reservation is also a county. Counties around us, so we're not too interested in COVID vaccines. So if anything, we helped vaccinate a lot of the surrounding county members who could not find vaccines elsewhere. Is there any part of that question I didn't touch on, Adriana?
They asked, the very last part was, what were your resolutions?
Well, I think just using the COVID funding that we had, which was huge, and just having a really excellent group of nurses on top of knowing what we needed and getting it ahead of time and staying on top of all those supplies and keeping the vaccine clinics well supplied. We used checklists every day to make sure that we weren't forgetting things, and that was really helpful.
And then one quick question before Dr. Wong begin her presentation is, how did you address vaccine hesitancy? I saw you had a strong belief in science. What else worked?
I think that the YouTube videos that were done by tribal leaders and spiritual leaders were very effective in convincing some folks who had hesitancy. I think the fact that we've had longevity with our medical staff helped. People who've been here for over 20, almost 30 years. A lot of us have been here a long time, and we've been fortunate enough to win the trust of our patients, and being able to talk with them both one-on-one and the public service announcements. We basically poured those out for weeks and weeks. It was once or twice a week, just sharing with people the real science and the real studies that were coming out about the vaccine. So it's not to say we didn't have hesitation. I mean, we don't have 100% take up of our population, but you know, over 95% for several age groups. But it was really due to a lot of different factors.
So if you have any additional questions for Amy, please type them in the chat box, and we would get to those during the Q&A after Dr. Wong's presentation. I now turn it over to you, Dr. Wong. Thank you for your flexibility. And yes, ma'am, a copy of the recording and presentations will be emailed to everyone that registered on Monday. I will send out an email letting you know that YouTube is, the recording is up on YouTube, and I will also give you access to all presentations or supplemental documentation that is provided during the presentation. Thank you.
Thank you. Are my slides up?
Yes, ma'am. You're in presentation mode.
Thank you. So thank you for this opportunity. Thank you also for sharing that story about the Menominee vaccine rollout and the success, Dr. Slagle. We have no disclosures today. And I do want to note that the views that we present today are our own and do not reflect the position or the policy of the VA or the US government. Before I begin, I also want to acknowledge my collaborators and mentors, as well as our funders. I also want to acknowledge the Gabrielino Tongva peoples as the traditional land caretakers of Tavagnar, in which the Greater Los Angeles VA, where I work, is located. And finally, I want to acknowledge that I'm a researcher with an interest in health equity, but I'm not Native. So while I can speak to the research and the data, I also welcome your experiences and your stories, and I'm here to learn from all of you as well. As a researcher, I want to examine questions that are of importance to the tribes and to the audience. And so I hope that this really is a chance to foster some dialogue. This is just an overview of what I'll be going over today. First off, with some background about the VA, then going into disparities within the VA on disparities in mortality and COVID-19. And finally, the majority of the presentation will examine the role of social determinants of health on disparities related to COVID-19. So to start off with some background on VA, this will help provide context for how we understand issues of health equity in this healthcare system. The VA has some unique features as a healthcare system. First off, veterans who receive care from VA do not need to have health insurance. And this has important implications for health equity, since requiring health insurance is often a barrier for patients of color to access health care. However, insurance is not the only barrier to accessing care, so VA has taken other steps to address these other barriers. For example, VA addresses other financial barriers to care through providing care at reduced costs to veterans with lower income or military service-related disability. VA also addresses some social needs, such as providing transportation to VA facilities. And finally, VA is also the nation's largest integrated healthcare system. American Indian and Alaska Native individuals have strong military ties with the US military. And in fact, they serve at higher rates than members of other racial groups. Despite their presence in the military and as veterans, we need more research on this population within the VA. Some veterans are eligible to receive care from both VA and Indian Health Services. And there are efforts to increase collaboration and coordination between VA, IHS, and tribal health programs to provide care to veterans who are eligible for care from multiple systems. For example, VA currently has memorandums of understanding set up to allow VA to reimburse for some care provided by IHS. Additionally, as part of VA's fourth mission to support the nation's healthcare system in times of emergencies, VA provided support to IHS facilities during the ongoing COVID-19 pandemic. That said, I do want to acknowledge that this collaboration is still very much a work in progress, and there's certainly room for improvement in collaborations with VA. Now I want to discuss some research that we did that explored racial ethnic disparities in mortality within VA. I've included a QR code at the bottom of this slide if you'd like to access the full study. This research came from a paper that was published in 2019 in Health Equity, where we examined racial ethnic differences in all-cause cancer and heart disease mortality in a national sample of veterans who used VA for care. This analysis took advantage of the racial ethnic diversity of the veterans who received care from VA. We conducted this analysis among veterans who used VA for ambulatory care between 2008 and 2009 and followed them through the end of 2011. So this slide presents our main findings. And before I dive into the results, I want to first orient you to this graph. So for each of the racial ethnic minoritized groups listed, we compared their likelihood of mortality to non-Hispanic white veterans, which is the reference group. And for the remainder of the presentation, I'll actually just refer to this group as white, but know that they are non-Hispanic. And so if each of the racial ethnic minoritized groups are above the horizontal line, which is at 1, that means they have a higher likelihood of mortality. If any part of the 95% confidence interval, so that's the vertical bar for each of the racial ethnic groups, if the vertical bar crosses the horizontal line at 1, then there's no difference in mortality. And if they are below the horizontal line, then they have a lower likelihood of mortality compared to white veterans. For all-cause mortality, we found that American Indian and Alaska Native veterans actually had a disparity in all-cause mortality compared to white veterans. For cancer and heart disease mortality, we did not find a difference in mortality compared to white veterans. These disparities within this sample of American Indian and Alaska Native veterans is comparable to disparities found by IHS in the IHS service areas from 2009 to 2011. Next, I want to move into disparities specific to COVID-19. There were initial studies that found high COVID-19 infection among Native American individuals, and many of these studies early in the pandemic were conducted among those living on reservations. At the time when we conducted our study, existing studies did not account for the fact that the pandemic had changed quite a bit. For example, we have more knowledge about disparities, we have better treatments, and more risk mitigation strategies. And as I'm sure many of you are aware of, some tribes actually implemented their own set of risk mitigation protocols. VA is also very much interested in understanding racial ethnic disparities in their veteran population from an operations standpoint. So we conducted a study that looked at time trends in racial ethnic differences in COVID-19 infection and mortality. And again, I've included a QR code at the bottom of this slide to access the full manuscript. We used data from 2020. And again, this data comes from a national sample of veterans, this time for those who were evaluated or received care for COVID-19 symptoms. Our study used 9 months of data from March 2020 to November 2020. We considered how patterns in COVID-19 infection changed over 3 time periods: spring, summer, and fall of 2020. And the way I've set up this graph, it shows the predicted probabilities of COVID-19 infection. American Indian and Alaska Native veterans are represented in green, and the reference group of white veterans are shown in blue. We see that in the summer and fall of 2020, American Indian and Alaska Native veterans had a statistically significantly higher probability of COVID-19 infection after accounting for age, gender, and CDC risk factors for severe COVID-19 compared to white veterans. We can also see how trends in COVID-19 infection among American Indian and Alaska Native veterans compared to other racial ethnic minoritized groups. So in the summer of 2020, multiple racial ethnic minoritized groups had a higher probability of COVID-19 infection compared to white veterans. However, in the fall of 2020, only American Indian and Alaska Native veterans still had a statistically significantly higher probability of COVID-19 infection. And in fact, they had the highest predicted probability among the groups that we included in our analysis. When we looked at mortality, again, green represents American Indian and Alaska Native veterans, and blue represents white veterans. We see that American Indian and Alaska Native veterans generally had a higher probability of mortality compared to white veterans, and this was statistically significantly greater in the summer of 2020. It's worth noting, though, that the probability of mortality did decrease over time. So, we see that there are disparities. Now it's important to understand why there are disparities. And I'll spend the remainder of this presentation exploring one potential contributor to these disparities, which is social determinants of health. That is, non-healthcare related factors that affect our health. There's a growing consensus that social determinants of health not only play an important role in health outcomes, but have also contributed to the racial ethnic disparities in the current COVID-19 pandemic. However, there's less research that has specifically focused on the social determinants that American Indian and Alaskan Native populations experience. And it's important to consider how social determinants, how different racial ethnic minoritized groups experience different social determinants. For American Indian and Alaska Native populations, their experiences in America is different from other racial ethnic groups given historic traumas, as well as continued racism and erasure. So what do we know about social determinants of health and American Indian and Alaska Native populations? At the time that we conducted this study, there was some, albeit limited, research that had explored neighborhood social determinants that are related to COVID-19 among American Indian and Alaska Native populations. Here are some of the potentially relevant neighborhood characteristics. These include living in neighborhoods with more households that lack plumbing, living in neighborhoods that are more socioeconomically disadvantaged, and living in neighborhoods that have more overcrowded households. Not only are these characteristics related to COVID-19 infection, but it's possible that American Indian and Alaska Native populations may also be more likely to live in neighborhoods with these characteristics compared to white individuals. So this leads us to wonder whether these neighborhood differences may in fact help to explain the disparity. It's important to tease out what factors are actually behind these disparities, because we can actually intervene on these factors. So for example, we can intervene on the neighborhood social determinants. And to analyze these factors, we use a statistical analysis called mediation. And the factors that may potentially explain the relationship of interest, we call them mediators. So this diagram here helps to illustrate what we mean by mediation. So first off, we have our main relation. Sorry, that I just got a notification from the VA. So this diagram here helps to explain what we mean by mediation. So first off, we have the main relationship that we're interested in, which is the disparity in COVID-19 test positivity between American Indian and Alaska Native veterans compared to white veterans. We're interested in identifying factors that contribute to greater COVID-19 infection among American Indian and Alaska Native veterans. There are some neighborhood characteristics that have been found to be associated with COVID-19, such as those mentioned on the previous slide. And American Indian and Alaska Native populations may be more likely to live in neighborhoods with these characteristics. So it's possible that greater exposure to these neighborhood characteristics may explain why American Indian and Alaska Native veterans are more likely to be infected by COVID-19. We call this mediation when a factor helps to explain the relationship we're interested in, which in this case is the COVID-19 disparity. Another factor to consider with regard to social determinants of health is proximity to reservations. That said, at the time that we conducted our study, most of the COVID-19 research on social determinants of health among American Indian and Alaska Native populations was done primarily among populations living on reservations. But there's no single representative American Indian and Alaska Native experience. For example, urban Indians may experience different social determinants than those living on reservations. One example of this is rurality compared to urbanicity, and this has huge implications for access to care. So we wanted to conduct a follow-up to our previous analysis that found that American Indian and Alaska Native veterans experienced disparities in COVID-19 infection. And in our current study, we examined the role of neighborhood social determinants in explaining the observed disparities. And again, I have a QR code at the bottom of the slide if you'd like to access the full study. Our study objectives were first to examine the mediating role of neighborhood characteristics, and second, whether the mediating effects of the neighborhood characteristics differed based on whether individuals resided on or near reservations. So essentially, our objective was to conduct a moderated mediation analysis. And as you recall from a few slides back, the mediator helps to explain the disparity. So in this case, we're interested in examining whether neighborhood characteristics mediated the American Indian and Alaska Native disparity in COVID-19 infection. However, mediators may not act the same way for all groups of people in the sample. We call this moderation when another factor, in this case, proximity to tribal lands, changes the mediator's effect. So as an illustrative example, we may hypothetically find that neighborhood socioeconomic status mediates the disparity. And furthermore, we might find that neighborhood socioeconomic status only mediates the disparity among individuals living in proximity to reservations, but that it does not mediate the disparity for those who do not live near reservations. So now on to the methods. Veteran data came from VA's COVID-19 database, as well as VA's electronic medical records. Neighborhood data came from the 2014 through 2018 census. Our sample included non-Hispanic white and non-Hispanic American Indian and Alaska Native veterans who were tested for COVID-19 between March 1st through August 25th, 2020. And for the rest of the presentation, I'll just refer to these two groups as white and American Indian and Alaska Native, but just do know that we excluded individuals from our analysis who identified as also being Hispanic. So now I'll go through our measures, and I'm using the same figure as 2 slides ago, so that I think this will help keep track of how all the variables fit together. So first, our independent variable is race, so whether veterans were American Indian, Alaska Native, or white. Our dependent variable was whether or not individuals tested positive for COVID-19. And our mediators were characteristics of the neighborhood, and we defined the neighborhood by census tract. We looked at 4 neighborhood characteristics. The first is the percent of households in the neighborhood that were overcrowded, and this is based on HUD's definition of greater than 1 person per room, and this is also a commonly used definition of overcrowded households. Our next neighborhood characteristic was the percent of households without complete plumbing, which the US Census defines as lacking 1 or more of the following: hot or cold running water, flushing toilet, or a bathtub or shower. Our third neighborhood characteristic was the percent of households without kitchen plumbing, which is defined as lacking 1 or more of the following: sink with a faucet, a stove or a range, or a refrigerator. And our fourth neighborhood characteristic was neighborhood socioeconomic status. Our moderator variable was proximity to tribal reservations. We identified this based on whether or not individuals resided in an IHS contract health service delivery county, which I'll abbreviate as CHSDA. IHS defines CHSDA counties as counties that include all or part of a reservation, or any county with a common boundary with a reservation. We controlled for age, gender, individual socioeconomic status, as well as CDC comorbidities for risk factors for serious COVID-19. As you can see in this map, CHSDA counties are located all across the United States. Our statistical analysis consisted of a moderated mediation analysis. We used Techen and Techen's inverse odds weighting mediation approach. So briefly, we calculated the mediation effects separately for CHSDA and non-CHSDA counties. To do so, we first calculated the total effect of the disparity. That is the disparity without accounting for any mediation. And then we decomposed this relationship into the direct effect. That's the component that's not mediated, and the indirect effect of the disparity. That's the part of the disparity that is mediated by a neighborhood characteristic. Then we compared the magnitudes of the mediated of the mediated effects in CHSDA and non-CHSDA counties to determine if they were statistically significantly different. And if they were, we consider this evidence of moderated mediation. We did this separately for each neighborhood characteristic. So here are our results, starting off with our sample characteristics. This table presents neighborhood characteristics for white and American Indian and Alaska Native veterans. We see that American Indian and Alaska Native veterans are more likely to live in CHSDA counties, live in neighborhoods with a greater percent of households that are considered overcrowded, that lack complete plumbing, that lack kitchen plumbing, and in neighborhoods with greater socioeconomic deprivation. When we look at COVID test positivity, we see that approximately 8% of white veterans in our sample tested positive compared to 11% of American Indian and Alaska Native veterans. When we consider differences by CHSDA and non-CHSDA counties, this bar graph shows that American Indian and Alaska Native veterans, which are shown in the blue bars, have a higher percent positivity than white veterans, shown in the gray bars, and that this difference is actually greater in CHSDA counties. So this table presents our moderated mediation results. I'm showing it in parts because to help make it less overwhelming with a lot of numbers. The indirect effect is the mediated effect. So if the indirect effect or the mediated effect is significant, that means that this neighborhood characteristic mediates the disparity. And we calculated this separately for CHSDA and non-CHSDA counties. So for CHSDA counties, we see that 3 of the 4 neighborhood characteristics mediate the disparity. And these are the percent of households that lack complete plumbing, the percent of households that lack kitchen plumbing, as well as neighborhood socioeconomic status. For non-CHSDA counties, we see that all 4 of the neighborhood characteristics mediated the disparity. And this final column is the comparison of the mediating effects between CHSDA and non-CHSDA counties. And as I mentioned, if the comparison is statistically significant, that means that the mediating effects differed. And we see that only one neighborhood characteristic is different, and that is the percent of households that lack kitchen plumbing. So what does this all mean? We found that neighborhood characteristics did in fact explain the disparity in COVID-19 infection. And in fact, 3 neighborhood characteristics mediated the disparity in both CHSDA and non-CHSDA counties. And these are the percent of households that lack complete plumbing, the percent of households that lack kitchen plumbing, and as well as neighborhood socioeconomic status. Additionally, the percent of households that lack kitchen plumbing explained more of the disparity among veterans living in CHSDA counties compared to veterans not living in CHSDA counties. And so now this is really where I'd welcome input from, well, I'd welcome input throughout the entire presentation, but I think I'd really welcome your thoughts on this, because I don't think that it's necessarily the percent of households that lack kitchen plumbing per se, but I think that this characteristic of the community, of the neighborhood, represents some underlying mechanism. And so, thinking through what is that mechanism and why is this mechanism stronger on reservations, and what does this mean in terms of how we can reduce disparities? And I have some thoughts that I'll share, but again, I'm interested to hear from all of you. So first off, lacking kitchen plumbing might indicate a lack of running water. And so individuals who lack kitchen plumbing have to travel have to travel to obtain water. This makes it difficult to social distance. And these households may congregate in areas where they fill up their water tanks. And this increases the likelihood for transmission. This also makes frequent hand washing challenging. Additionally, it's possible that the percent of households that without kitchen plumbing, this characteristic actually captures a household food insecurity, because, as you'll recall, one of the components of lacking kitchen plumbing is not having a refrigerator. So these households might have to frequently obtain food, which makes it difficult to social distance. And that may increase their likelihood of being exposed to COVID-19. And why is this stronger on tribal lands? One thought is that reservations may actually these communities may be more food insecure. And by that, I mean, it's possible they might have fewer grocery stores. So not only are individuals going to the grocery store more often, they're going to the same grocery store. And that just really presents challenges for social distancing and increases the likelihood of contracting COVID-19. And I think there are implications for how we think about risk factors for COVID-19, that potentially lacking running water and food insecurity might be potential risk factors and might help to explain the disparity. I really quickly want to go over some study limitations. Our study has limited generalizability to non-VA populations. We define the neighborhoods by census tracts, but this might not be the best way to actually capture the lived experiences of what consists of a neighborhood. Our analyses are cross-sectional, so this precludes strict causal interpretation. We did not know tribal affiliations of veterans. Our race data are self-reported, and we did not include those who identified as multi-race or Hispanic ethnicity. Implications of our study are, first off, that neighborhood social determinants of health do help to explain the disparities in COVID-19 infection experienced among American Indian and Alaska Native individuals. Also, disaster planning should include addressing neighborhood social determinants of health. Our study also suggests that future studies on American Indian and Alaska Native individuals should not be limited to populations living on reservations. The risk factors that we identified in this study should inform risk factor screening. And finally, public health measures should be tailored to the social context of diverse populations. And by that, we mean that instead of just always recommending the ideal, public health practitioners and healthcare providers should consider, making recommendations that are realistic to the social context and culture of their patients. And thank you so much for taking the time to listen to this presentation today.